Hello friends, myself Dr. Rakesh Tiwari. Today I will discuss about the basics of the plates.
So the basic plate is actually we start with the DCP. So these are the varieties of the DCP. This is the broad DCP 4.5 mm. This is the narrow DCP 4.5 mm and this is the DCP of the 3.5 mm. We have the two system, that is the 3.5 mm screws, that is based upon the size of the screw, the diameter of the screw, that is 3.5 mm screw and the 4.5 mm screw. So these two plates will have the 4.5 mm screws in their holes. So you can see that the 4.5 mm screw will get fixed to it, whereas this is the 3.5 mm and the screw will not go through this because this screw is 4.5 mm size. How to identify the DCP is the broad and narrow are identified based upon the orientation of the screw holes. You can see that they have the zigzag pattern, that is the broad DCP, whereas this has the straight. The DCP usually have the screws and there is a spacing in between the proximal and the distal fragment. You can see here that there is no hole. It is for the fracture side. So the fracture side will come over here. These are for the one side of the fracture, that is the proximal fragment. This side is for the distal fragment. Like this they have divided, and this space they have left for the fracture side to accommodate. Now the principle of the DCP is the spherical gliding principle. Just see here, the holes of the plate are for the screws are oval in shape. They are not circular, they are actually oval in shape, and they are the combination of cylinder of inclined. The one is the vertical or the inclined cylinder and another is the horizontal cylinder. So we can say that in this cylinder the ball or this head of the screw will move like a ball. So when we insert it eccentrically on one side, it rotates, it moves. The ball moves from vertical to horizontal, and in this plane it can move. So what is the principle here? We fix the one fragment while the screw is in the central mode, or we can say it as a neutral mode. When we fix the screw in the center of the hole, it is the neutral mode, and the another screw when we fix in the eccentric mode, or we say it as a compression mode. So when we tighten while we keeping this in eccentric away from the fracture side, that is we will insert the second screw in the opposite fragment of the bone over the screw should be in the eccentric mode. So we will fix it over here. This is the central mode or the neutral mode, and this is the eccentric mode or the compression mode. So when we tighten the screw will move towards the fracture side, and this will cause the bone to move towards the fracture side, and this will create a compression. So that is the mechanism how we get the compression here in the DCP. If we do not want the compression, then just insert the screw in the neutral mode, that is center, and all the screws should be in the center. If we want the compression mode, the one screw on this side should be in the center. The opposite fragment should be fixed in the eccentric mode, so that we can get a compression at the fracture side. So that is the principle, spherical gliding principle. How to identify? They are oval in shape in order to have a compression mode. Now what is the disadvantage of this DCP? The DCP in the under surface, if you see, the under surface is all flat. So when it goes into the plate, the plate, when it gets fit over the bone periosteum gets devascularized because of the compression. Because the undersurface of the plate and the bone, in between the periosteum, it gets compressed, and the periosteum is mainly the vascular supply of the bone. So it devascularizes the bone. So for this, they have devised a low contact or the limited contact DCP. The limited contact DCP, I do not have in this table, but it is just the same as DCP. However, they have made a grooves over here. The empty spaces or the vacant spaces here in between the screws, they have created a grooves like you see in this plate. इस तरह के grooves बना दिए, so that when it gets over the bone, this much of the space or this much of the periosteum will be preserved. It will not get compressed. This is the basic idea of making the LC DCP or low contact DCP. Now again there was a difficulty in LCDCP also, because when you put screws, the screws can toggle. The screws can toggle like this, you can see. So this creates problem with the implant failure, this creates implant loosening. So in order to solve this problem, they have come with a new mechanism or a new plate, that is locking plate. So that's why the locking plate came into the picture. The locking plate basically has the mechanism of getting fixation of the plate or the locking of the plate with screws. So when you tighten the screw, it gets locked. The screw cannot move. So it gives them better stability, the better fixation, better purchase of the implant. So basically this is actually a combi hole plate. This is not exactly the pure locking type of plate. It has both the holes. It is a 8-shaped hole. You can see that is a 8-shaped hole. The one side of the hole is threaded, the other is non-threaded. And always remember, it is always towards the fracture side it is threaded, and away from the fracture side it is non-threaded. So this is the locking hole, this is the non-locking hole. So this plate can be used for both the purposes. If you want to have this plate for locking mode, just put the screw in the locking mode. This is the locking screw in the locking mode. And if you do not want the locking type of fixation, you just put the non-locking screw in the opposite hole or the non-locking hole. So this is the basic mechanism, while you cannot put the two screws simultaneously in the same hole. So you can use this plate for the locking type of mechanism when you need. The main indications of locking plate is the periarticular fracture, metaphyseal fracture, that is near the joint, or in the osteoporotic fracture where the bone quality is not good and you need a rigid type of fixation, a good type of fixation, so have a better purchase of the implant. And the third possibility is when you have a periprosthetic type of fracture, when you have the fracture near the prosthesis. So these are the basic indications of the locking plate. Now we have devised the numerous other locking mechanism for the anatomically particular region. For anatomical region like this, we have this plate. This is actually the distal femur locking plate. The distal femur locking compression plate. This is for the distal femur fragment. We have multiple options, 1, 2, 3, 4, 5, 6, 7. We have the 7 screw options for the distal femur fragment and this much of the hole in the shaft of the femur. So again, this is a combi hole. The locking and the non-locking screws can go in this. And always remember, towards the fracture side, that is this hole will have the thread, this hole will have thread, this hole will have thread. These are the locking. The opposite is non-locking. So this is the way how you identify the locking plate. Now one more plate is left, that is the 1/3 tubular plate. Now this is the 1/3 tubular plate. It is actually a semicircular type, or you can say it is a circular type of a plate. The cross section is actually a circular, 1/3 of a circle, and these are the holes which are non-locking. And the main indication is when you go for the fixation of small bones like ulna or like fibula, you can insert this type of bone. This is 1/3 tubular bone. Another plate which is not here is the recon plate. The recon plate is actually as the same as these type of plates, whereas they have the mechanism of getting, we can bend them in any direction in any plane. So the recon plate is mainly used for the particular difficult anatomical region where we want anatomical contouring of the plate, so we can use them. Now another set of plate. This is actually barrel plate, or you can say this is sliding hip screw plate, and this is the dynamic condylar screw plate. So this is DHS and this is DCS. The main mechanism, the main indication is intertrochanteric fracture. The DHS was mainly made for the fixation of the intertrochanteric fractures, whereas the DCS was made initially for the intercondylar humerus, intercondylar femur, the distal femur intercondylar part fixation. But however, they are now used for mainly subtrochanteric type of fractures or intertrochanteric type of fractures or valgus osteotomy, the DCS. The main difference between the two is the angle, that is the neck shaft angle or the barrel plate angle. This is the barrel, this is the plate, barrel plate. The main angle between the barrel and the plate is around 125 to 140 degree. So this angle is 125 to 140 degree, whereas in DCS it is 95 degree. So this angle is the 95 degree. So this is the basic difference between the two. Another plate which I want to have a look, is this. It is same as DHS, however it has a extension of this plate over the greater trochanter. So this is actually a trochanter stabilizing plate. This is mainly used, the indication is where you have the comminution in the greater trochanter or the lateral wall of the greater trochanter, then you use this trochanteric stabilizing plate. However, this is now not being used. It is now going out of favor, mainly because of the PFN. Now the implant of choice for the intertrochanteric fracture, for unstable, for lateral wall comminution or for greater trochanter comminution, it is the proximal femoral nail, which is the treatment of choice or the implant of choice nowadays. So this is actually the lag screw or the Richard screw. So this will go in this barrel. You can see that the barrel has the cannulation. So the screw will get fixed over the head of the femur and the neck of the femur, and the plate is going to fix in the shaft of the femur. So when you fix this and this, there is a play between the two, and this is the main principle, because now the fracture will get collapse in a controlled way. So we can control this collapse or control this compression, and this is known as controlled cancellous collapse. So that is the principle of the DHS. And the correct entry point or the correct site of entry of this screw is center and center. Center in the AP view, center of the head and neck, center of head and neck in the lateral view. But however, if this position is not, you are not going to achieve this, it is very difficult to achieve the center in the AP and center in the lateral, then it is posterior-inferior, which is the acceptable position. The posterior in the AP view and posterior in the lateral view and inferior in the AP view. So you should aim for the posterior-inferior aspect of the humeral or the femoral head. That is, the bone quality is really very great and you will get a good purchase. So that is the center, the first position of acceptance, and the second position which is acceptable is posterior-inferior. However, the superior and the anterior, that is the anterior-superior location or the anterior-superior quadrant of the femoral head should not be aimed upon, because there the cutoff chances, the failure rate of DHS or DCS is highest. The second thing you must know about the DHS is the TAD distance, that is the tip apex distance. The tip apex distance is actually, you measure the tip of the head of the femur and the apex, the tip of the implant and the apex of the head of the femur, the center of in the cartilaginous portion. If you measure this distance in the AP and the lateral view, it should be less than 25 mm. The sum of the TAD, AP and lateral should be less than 25 mm, then only it will not going to fail. If it is more than 25 mm, the failure rate of DHS is high. So this is all about the DHS, that is a sliding hip screw assembly. Just